Now, we are going to continue the discussion on the understanding of basal ganglia in terms of the anatomy, in terms of the functions, in terms of the neurochemistry there, in terms of the regulation of motor function by the basal ganglia. We all know basal ganglia composed of certain parts, and this is not one particular organ. The one major important organ, this is the anterior part or the front part of the brain, and this is the temporal pole, and this is the frontal pole here. And then you have the medial part is the thalamus. There are two thalami separated by the corpus callosum there, and the thalamus is there, and you have the C-shaped structure here, and that is your caudate nucleus, which is lateral to the lateral ventricle, and thalami are lateral to the third ventricle. Third ventricle is in between, and thalami are on either side. And the caudate nucleus is on the lateral border of the lateral ventricles. Each caudate nucleus. Caudate nucleus has got a head, a body, and a tail. At the tail, there is another nucleus called the amygdala. This is that amygdala which we are talking about. And this is the tail of the caudate nucleus on the other side. And medial to the caudate nucleus, or medial to the caudate nucleus, you have the globus pallidus externa and globus pallidus interna. And in the C loop of the caudate nucleus, you have what is called the putamen, which is the projecting part here. So that is the putamen. Now again, reiterating the parts of basal ganglia: caudate nucleus, putamen, together are called the neostriatum, and you have the globus pallidus externa, globus pallidus interna, which are medial to the putamen but lateral to the thalamus. The thalamus is also a part of the basal ganglia, and it is separated by the third ventricle in between, and there is a subthalamic nucleus which is not seen in the view, and there is another area called the substantia nigra, which is in fact is in the ventral aspect of the midbrain. So these so it is called pallidum. Why it is called pallidum or pallidus? Globus pallidus. It is globular, so it is globus. Pallidum means old. Neostriatum and pallidostriatum. Pallidostriatum means that one. Nobody calls it as striatum today. We call it as lentiform nucleus along with the putamen. Putamen plus globus pallidus is called the lentiform nucleus, and originally that was referred to as a pallidostriatum. And caudate nucleus was called the striatum or neo. Now, once the putamen has got function in association with the caudate nucleus, the nomenclature of neostriatum has come, and the pallidostriatum has been called now as pallidum. And again, it has got two parts, interna and externa. Functional divisions are there. Okay, so this is so far so good, and I made some slides after yesterday's lecture using yesterday's time. So to save time, those slides will be very useful. So we all understand now the motor activity is coordinated basically from the cerebral cortex, and it sends impulses to the brainstem, and that brainstem impulses are cortico-bulbar tracts and corticospinal tracts. And corticobulbar and corticospinal tracts innervate the muscles, and these muscles will send feedback that goes via the sensory to the brainstem. Again, it reaches the thalamus, and thalamus gives an input to the cerebral cortex to coordinate the motor function. In addition, we have coordinating organs, the cerebellum, the vestibule, and then we have got the ocular feedback, and you have also got the vestibular sensory. All these are essential for proper position, walking, and then coordination of the movement. That is why in cerebral disorders we have incoordination, finger nose test. First pointing will be there. There will be hypotonia. There will be pendular knee jerks. In vestibular also we have ataxia. In ocular lesions also we have ataxia. In sensory we have peripheral ataxia. All those are functions of coordination. Now, what is the function of the basal ganglia? These have three important functions: initiation of movement, and then control or regulation or inhibition of movement, and the third one is modulation or amplification of the wanted movement and disamplification of the unwanted movement. Suppose the limb has to flex at the elbow. There is a smooth contraction of the biceps. There is a nice relaxation of the opposite group of muscles, triceps. And this, just if the biceps once contracts and keeps quiet, there is no use. If I want to lift weight or sustain the force of contraction for a period until the muscle is fatigued, I require to do that while walking, while running, while standing, while doing any task, by lifting weights. You require sustained motor activity, and sustenance of motor activity will require enhancement of the force of contraction generated by the cerebral cortex of the agonistic group of muscles, and simultaneous inhibition or relaxation to the same length of time of the antagonistic group of muscles. And that is what is called modulation. And that is a function of the basal ganglia. In the absence of this function of the basal ganglion disorders, either you have poor initiation, and there will be poor inhibition of the opposite muscles. There will be hypertonia. There will be bradykinesia. There will be akinesia. There will be ataxia. There will be speech disturbance. All that. When there is a deficiency of the excitatory impulse. The other way around, if the excitatory impulses are more and the inhibitory impulses are less, there will be higher. There will be dystonia, athetosis, tremors, and then spasms, tics, myoclonus, and all those things, which are the hyperactive hypotonic system. The second part. The first one is hypoactive hypertonic antagonistic system. Both can occur with excess or less of functioning of the dopamine there in the basal ganglia. The main neurotransmitter is the dopamine. We should have now see how the dopamine controls. Now this is yesterday I have shown you. So this is the cross section, the coronal section of this one. This is the two lateral ventricles there. This is the third ventricle. At the tip of the third ventricle, you have the hypothalamus, and the green one here is the thalamus there. And then this is the subthalamic nuclei here. And in the midbrain, you have the substantia nigra. This is the caudate nucleus, the head of the caudate nucleus. And then the putamen and the caudate nucleus together are called the neostriatum. The pallidum is interna and externa. You can see two different parts, internal part and the external part. So that is how you can see the structure of the various basal ganglion components, how they are disposed in relation to one another. And ultimately, the thalamus projects onto the cortex to influence. So they starts with cortex, goes to the striatum, goes to the pallidum, either internal or external to the internal in the indirect pathway, and then projected onto the thalamus, thalamocortical projection that thus controls. So these are initiators, and then the inhibitors and the modulators also. Okay. So the actual execution is from the cortex, but that requires to be modulated by this. So what is this diagram? You would not have seen earlier. This is about the thalamus. How many nuclei are there in thalamus? So many nuclei are there. We are concerned here in this about ventral anterior and ventral lateral nucleus. VL and VA only we have talked about. There are other called the ventral posterior, ventral posterior medial, and ventral posterior inferior, posterior lateral, midline, and the lateral. These are all ventral, pontine, ventral, and nuclei. They're called the VPs. VP is the ventral posterior nuclei. The VA and VL are anterior and lateral nuclei. We have also called LD, which is the dorsal nucleus, lateral dorsal, and LP, which is the lateral posterior nucleus. There is a pulvinar of the thalamus, the lateral geniculate body, and the medial geniculate body. This is with the auditory, this is with the ophthalmic. It coordinates the movements related to the vestibule and also movements related to the eyes and the internal medullary lamina. And there is this lamina is internal medullary divided into internal medullary lamina and superior and inferior lamina. There is an anterior part, there is a median part, and the medial part next to the median. It's about thalamus. Very great lecture again about the functions and connections of thalamus, which are out of context for today's presentation. Suffice to know that we are interested in this VA and VL as far as the basal ganglia are concerned. All those yellow ones are lateral nuclei, the red colored ones are the medial nuclei, and the dark green color is the anterior nuclei. Now, if you ask me the functions, this is the chart just prepared long time back, and sometime later we will see that chart. Okay, now this is important. So the basal ganglia not only control, coordinate, initiate, inhibit, and modulate movement through the motor cortex, they also have a role in cognition. What is cognition? Cognition is a function of the prefrontal cortex. Motor activity is a function of the motor cortex and premotor cortex and the sensory, great sensory cortex. Great sensory cortex, motor cortex, premotor cortex together will control the motor function. Sensory gives the feedback necessary to regulate the motor function. Motor cortex initiates the motor function under the influence the premotor cortex, and that is the motor part, mainly through the putamen. Yesterday we have seen there are indirect pathway and the direct pathway and substantia nigra influences that putamen through that, and the caudate nucleus of course also through the motor cortex. Then the prefrontal cortex is important for cognition. Cognition, and third, the VTA nuclei of the thalamus, they control through the amygdala what is called the emotional component of that. So basal ganglia dysfunction can cause motor symptoms, can cause cognitive difficulties, can cause emotional difficulties also. In Parkinsonism, we see all of them. So there will be an emotionally disturbed face will be like, sort of rubber is stretched on the face, no facial expression, no grimaces, no smiling, my crust and the mouth is closed, and the person loses the emotional component and also cognition also. As the disease advances, they will not be able to cognize what they have earlier cognized. In addition to the kinesia, bradykinesia, hypokinesia, hypertonia, and then the ataxia and tremor, and all that together with these things it will come. So this is another important thing which I did not tell you. So it has got the motor component through the motor cortex, the second through the prefrontal cortex, the cognitive component, cognitive behavioral component, and the cingulate cortex through the amygdala. It is important for the emotional component of the body. Okay. So far, so good. So let us now go back to what we learned yesterday. So now all of you very easily, quickly recognize these pictures because whatever I have drawn yesterday, the same pictures I have put here. So functional anatomy. We call it as a schematic representation because this is for understanding. This is not exactly how they are, but more or less they are like that as you have seen in the previous diagram. The first one is the caudate nucleus. The second one is the is the putamen, and the vertical one and the pie-like one is the globus pallidus interna and the externa, that is 3. The fourth one is the thalamus. Both the thalami are separated by the third ventricle and there are subthalamic nuclei. The fifth one and the sixth one I forgot to number, and that is the substantia nigra, which is in the midbrain. Okay, these are the, if you ask me to write the notes, short notes on the structural anatomy of basal ganglia, you should put this picture and say 1 caudate nucleus, 2 sorry, somebody is joining, 1 caudate nucleus, 2 putamen, 3 globus pallidus interna and externa, 4 thalamus with the VA and the VL nuclei, which are important for us out of the so many nuclei of the thalamus. And then the subthalamic nucleus, the substantia nigra, it has got 2 parts, substantia nigra SN, pars compacta SN, pars means part, reticularis, PR, SNPC, SNPR. Why it is black in color? Because of the excess synthesis of dopamine there. Dopamine precursor, tyrosine, is a dark colored pigment, amino acid. And that dark color is due to the excess dopaminergic activities there. That is why it is dark in color. Nigra means dark, substantia nigra, black substance. The blackness is due to the dopamine content. Once there is a depletion in the dopamine content, if you see the MRI, the blackness becomes gray, and finally substantia nigra, the blackness may not be there, represented some by faint white line there in the MRI. That is the importance of knowing about the substantia nigra. And as you see, it is bilateral. It is the one hemisphere, another hemisphere, both sides. And this is the division of the midbrain there. Okay, that is why the substantia nigra is in the midbrain. Okay, now what did we do? So substantia nigra is the sixth one, and then we have the caudate nucleus. The plus putamen together are called the striatum, and then putamen plus globus pallidus is called the lentiform nucleus, globus pallidus interna and globus pallidus externa, thalamus, VN nucleus, VL nucleus, subthalamic nuclei. 3 important functions. Number 1, initiation. Number 2, inhibition of the opposite unnecessary activity, inhibition. And number 3 is the modulation of what? Of the skeletal muscle. That's the skeletal muscle. So that's how it comes. The premotor, this is the sensory cortex there, and this is the premotor motor cortex, and the premotor cortex, the frontal cortex, and then the amygdala related, the the emotional component. All these will send impulses down to the skeletal muscle, influenced by the basal ganglia. Again, caudate nucleus plus putamen is called the neostriatum. Globus pallidus plus putamen is called lentiform nucleus. It was the paleostriatum earlier. It was called, no more it is called paleostriatum because putamen going into the neostriatum. Thalamus, of course, we have told. Now, let us first see what we have seen yesterday, and we'll continue from there what we have done. Now, direct pathway increases the motor activity. What is the function of the direct pathway? It increases the motor activity or initiates the motor activity. So from the cortical neurons, they're discharging onto the caudate nucleus C and the putamen. and the putamen P here, and the neurons end up there to stimulate the another order of neurons. And we know the mediator is glutamate. That means when there is a stimulation or action potential generated, glutamate is secreted. We know how glutamate perpetuates the action potential because once the the channels are open, there will be more influx of the sodium and calcium in the internal positive charges more, and that internal positive charge leads to breakage of the threshold potential. That results in the action potential. That results in the post-synaptic excitatory potential, which is nothing but the plus here, all the increased potential, and there is excess generation of glutamic acid there. When the glutamic acid is there, its nature is to stimulate it both from the caudate nucleus and from the nucleus and from the putamen, the stimuli onto the blue colored ones, which is the blue colored ones are the GABA and the red colored one is the glutamate. Okay. And now there is an increase in this action potential in these neurons, which are going on to the internal part of the globus pallidus. And that means there is excess secretion of GABA. GABA, we know, is an inhibitory neurotransmitter. Glutamate is an excitatory neurotransmitter. So it excited and then lot of GABA is produced. GABA is an inhibitory neurotransmitter. How does it do? Because it allows the potassium to go and the chloride to come in. Internal negativity will occur. Internal negativity means the membrane is hyperpolarized. It is called I forgot to tell you yesterday. More internal positivity is called threshold potential is crossed. There are three types. First is called the resting membrane potential. Then is called the threshold potential. Then the action potential, and that leads to excitatory post-synaptic excitatory potential, PSEP. This is the positive side through the glutamate. On the negative side, what will happen is resting membrane potential, and the resting membrane potential is more negative now because the chloride has left, potassium has left and chloride has come in. Resting membrane potential, more negative ions here. More negative ions means threshold potential cannot be broken, so no action potential is produced. And then post-synaptic inhibitory potential. This is the role of the inhibitory part. This is the excitatory part. So the GABA, because of its inhibition, it is an inhibitory neurotransmitter. So there will be less of GABA here because this is all is inhibited. Less of GABA. GABA is, we know, is an inhibitor of the activity. Less of GABA means less of inhibition. Less of inhibition means more stimulation. And that goes to the cortex. Cortex action is modulated, motor activity or initiation, and is started. You would have understood now, isn't it? Yesterday also we looked at it. At the membrane level, the resting membrane potential, both positives and negatives are same. When there is more positivity inside and than the outside, then it becomes the threshold potential is broken, the barrier is broken, action potential starts, it propagates via the axon of the neuron and ends in post-synaptic excitatory potential at the end. The converse is, if there is efflux of potassium and influx of chloride, there will be more negative charges. Membrane is hyperpolarized. Hyperpolarized state, it cannot cross the threshold potential. No action potential is generated. The end result is post-synaptic inhibitory potential will be the end result. That is the function of GABA, whereas excitatory potential is the function of the glutamate. Now, here the GABA has perpetuated the action here because it is an excitatory neurotransmitter. So these neurons are excited and more GABA is glutamate has excited these things, and the more GABA is produced. GABA is inhibitory neurotransmitter. This neuron is inhibited, so there is less GABA here. Less GABA here is less inhibition. That means disinhibition. That means stimulation. That means motor activity. That's how it happens. This is the direct pathway. So what are the organs involved now? Cortex, putamen, caudate nucleus, and the GPI, the thalamus, and the cortex. Mediators, glutamine, GABA, GABA, glutamine. You can write down now like that. So cortex, and then caudate, and plus putamen, one group. The next level is the GPI, interna. Next is the thalamus, and thalamus to cortex. Here it is glutamate. Here it is G-GABA. Here it is GABA. And here it is glutamate. You can write another table also like that, simplifying these things. Okay. Now, what about the, this is we have not discussed earlier. This we will see today. What is that? This is the indirect pathway. What is the role of the indirect pathway? It is to inhibit the motor activity of what? Not of the wanted group of muscles, of the unwanted group of muscles. That means the antagonistic group of muscles. If a contraction were to be there, the agonistic group of muscles should be facilitated and stimulated, and the antagonistic group muscles should be inhibited and not allowed to contract simultaneously. Then otherwise no movement will result. And that is what exactly the indirect pathway does. Now, what are the things that are involved in the indirect pathway? As usual, cortex, as usual, cortex is the starting point, then is the caudate plus putamen, and then you have got the GPE, externa now, and GPE to subthalamic nucleus to GPI to thalamus, and thalamus to cortex. Okay, these are the organs involved. What is the end result? There is a decrease in the motor activity of the antagonistic muscles or unwanted muscles, isn't it? So how does it occur? So same thing. The first order neuron starts from the cortex. They end up in the caudate nucleus. They end up in the putamen, and then they produce an excitatory stimulus. Same GABA, excitatory neurotransmitter. And now, instead of the previous slide, the ones are going not into the externa, but into the, not here, but they are going into the interna. Here, what is happening? The neurons are terminating in the interna, in the indirect pathway, and there the other order neuron starts. Instead of that going this way, it will go down to the thalamus, subthalamic nucleus, subthalamic nucleus. So when this is excitatory potential is more, then there will be GABA. GABA will be secreted here. GABA is an inhibitory neurotransmitter. There is more inhibition, more GABA, more inhibition. So this neuron is inhibited. So end result is here, there is again GABA is decreased. So there is a decrease of GABA. Decrease of GABA is decrease of inhibition. Decrease of GABA is decrease of inhibition. Decrease of inhibition is excitation. And that is glutamate is the transmitter now. And glutamate, there will be there will be action potential, and very profound action potential comes, and it is a positive neurotransmitter. Excess GABA, glutamate is released. The red one is glutamate. Now this is a stimulatory one, so it stimulates this neuron. So this neuron from the globus pallidus, from the externus to the subthalamic to the internus to the thalamus. So there is more of the neuronal discharge here. More of GABA is produced. We know GABA is inhibitory, so it inhibits the thalamic nuclei. So the inhibition continues here, and ultimately cortex is inhibited. Motor activity is decreased. Of what? Of unwanted motor activity. Okay, I'm again tracing. It starts in the cortex, goes to the caudate nucleus and the putamen, and then from there to the externa, from the externa to the subthalamus, subthalamic nucleus to the interna, interna to the thalamus, thalamus to the cortex. That is the indirect path. How does it act? From the cortex, the first neuron stimulates the caudate nucleus in the putamen. Mediator is glutamin. Glutamin is a positive neurotransmitter or a stimulatory or excitatory neurotransmitter. It stimulates or excites the neurons that are there in the putamen and caudate nucleus, and these neurons terminate in the globus pallidus externa. And when these neurons are supposed to secrete GABA, when they're stimulated, they secrete more GABA. More GABA is more inhibition. So the next order neuron is inhibited, and end result is less GABA is produced here. Less GABA here means less inhibition. Less inhibition means the subthalamic nuclei are supposed to discharge, and the inhibition was there earlier. Now the inhibition is removed. They keep on discharging, and that is transmitter is glutamate, and more glutamate occurs in the interna. More glutamate is stimulatory, so it stimulates the next order neuron, and there will be a hyperstimulation of that, which results in excess GABA in the thalamus. And that means excess GABA is a negative neurotransmitter. Excess GABA in a negative neurotransmitter means more inhibition. More inhibition means less of the potentials going in from the thalamus to the cortex. So cortex is suppressed in the unwanted motor activity. Did you get it? One of you can answer, either Meghna or Deepa.
Yes, sir.
Now you summarize the internal pathway, indirect pathway.
The structures involved are cortex, striatum, globus pallidus externa, subthalamic nuclei, interna, thalamus, and again to cortex.
Correct. Transmitters involved are
glutamate and
glutamate, GABA, glutamate, GABA. The order: glutamate,
yes,
GABA, glutamate,
yes,
GABA, glutamate.
Yes, sir. First, cortex sends the impulse action potentials to striatum. The mediator is neurotransmitter is a glutamate, which is excitatory, which sends to globus pallidus externa, which releases the GABA, which is inhibitory. Less GABA, less inhibition, which goes to subthalamic nuclei. And,
not less GABA, more GABA, less. More GABA. GABA is increased, stimulated.
Yes,
more
yes.
GABA is more inhibitory. More inhibitory. So that so much the action potential to the subthalamus is inhibited. So then there will be less GABA there at the end of the subthalamic.
Yes, yes.
Less GABA is less inhibition there.
Less inhibition.
That
and
means
then,
stimulation.
Yes, sir. So glutamate is
more in the interna.
Interna, which causes hyperstimulation
Of the GABA. That means more GABA is secreted in the thalamus.
Thalamus, which causes more inhibition and less action potentials, and cortex,
is
which
causes suppressed and motor activity is reduced.
Yes, yes, sir.
The previous one, what happened? Motor activity is increased. Because there is no play of the subthalamic nucleus. Subthalamic nucleus is something like a sort of pacer of the basal ganglia, as it is said in the books. Means how that is modulating the inhibition here. And if you see the dopamine, this one, the indirect pathway and direct pathway are again influenced by the dopamine, as we see in the subsequent slides. Now I hope you understood the internal pathway, direct pathway, and the indirect pathway. Direct pathway, again I am telling, cortex, striatum, interna, thalamus, cortex. Transmitters, glutamate, GABA, GABA, glutamate. Okay? And end result, motor activity is increased. Okay. Whereas when you come here, the structures involved are cortex, striatum, externa, subthalamic nucleus, interna, thalamus, cortex. Transmitters are glutamate, more GABA, less GABA, more glutamate, more GABA, less GABA. So less glutamate at the end. That is, motor activity is reduced. Okay. Understood?
Yes, sir.
Shall we go for the next one, Magna and Deepa?
Yes, sir.
Okay. Now, you can close your mic. Now, this pathway is called the Nigro-Striatal pathway. Why? It starts from the substantia nigra and goes to the striatum. That's all. But the rest of it is following the internal and external pathways. Okay. So its connection is from the substantia nigra, it influences the striatum. And we know what striatum does in the internal external, the direct pathway, the internal pathway, and that is augmented or inhibited. If it goes to the external pathway or direct pathway, it augments the motor contraction of the agonist. If it goes to the indirect pathway, it augments the inhibition of the agonistic muscles. That is how the substantia nigra works. Substantia nigra, SN zone compacta, and then the reticularis. SNPC, pars compacta, SNPR. Substantia nigra has two parts. Substantia nigra pars compacta is that one, and substantia nigra pars reticularis is this one. Now, we don't have much to do with the reticularis part at the moment. But this is essential for a different purpose. As I told you, basal ganglia have a purpose of the cognition and emotion. There the reticularis will come. As far as the motor activity is concerned, it is the dopaminergic part or dopamine rich part or the black part which is important. Now what does it do? The diagram is the same previous diagram. Extra what we have done, we have taken from here this black line and then given it to the caudate nucleus, and the putamen also called the striatum. That is why it is called the nigrostriatal pathway. Now, what does the direct pathway do normally? Direct pathway is from the striatum, it goes to the interna to the thalamus, thalamus to the cortex. Cortex, striatum, interna, thalamus, cortex. That is the direct pathway. Now, on top of that, we have an augmentation from the substantia nigra. In fact, this is the controller of the basal ganglia because dopamine is the main mediator. The other are already going on. The background are baseline mediators, the direct pathway and indirect pathway. On top of which, the influence is by the dopamine for augmentation. Now, dopamine has got two types of receptors, dopamine 1 receptor and dopamine 2 receptors. So if the discharge of the dopamine, here what is the discharge here at this point, which is called the dopamine is the discharge. Dopamine is the discharge here as well as there in both the places. And this dopamine is excited when it is on the dopamine 1 receptor. If it sits on the dopamine 1 receptor, it is excitatory. How does it do it? Yesterday I showed you, once again I will show. So it excites. What is this doing? GABA, the glutamate, that's also exciting. Whereas what is this doing? This is also exciting. That means there is hyper excitation of these blue colored neurons, which are going from the caudate nucleus and the putamen to the globus pallidus interna. That means a lot of GABA is produced because these neurons are, when they're secreting GABA and they're hyperstimulated, so more GABA is more inhibition. More inhibition is this neuron is more inhibited. So that means less GABA here. GABA is very much decreased. That means very less inhibition. That is what happens. The positive activity is unopposed and there will be increase in the motor activity through the thalamus to the cortex. This potentiates, enhances, modulates, augments, sustains. So many words. It potentiates, augments, enhances, sustains the motor contraction. Suppose I have to lift a weight of 5 kilograms from the floor to the upper shelf. At least 2 to 3 minutes I have to keep the motor activity is sustained. And that sustenance, that perpetuation, that augmentation, that power is generated by this particular pathway, which is called the DP1 pathway, striatonigral pathway DP1. That is D1P pathway. That is the dopamine 1 receptor pathway, not DP1. D1P pathway, striatonigral pathway, D1P pathway. Yet D1P receptor is D1 receptor is excitatory. This excitatory influence joins hands with the excitatory influence of the glutamate from the cortex. Glutamate plus dopamine together further stimulate this blue colored neuron, and that blue neuron, we know by its very nature, secretes GABA, and more GABA is secreted. More GABA means the next neuron is more inhibited. More inhibited means there is a very little GABA or no GABA here at this point. Little GABA means decrease in the inhibition. Decrease in the inhibition means more of disinhibition. More of disinhibition means more of stimulation. That is cortical stimulation, increasing the motor activity from the substantia nigra pars compacta. Understood? Now this is an augmentation of the direct pathway by the D1 receptors. Okay. Can you hear?
Sir,
You did not get it.
no, sir. There was a signal problem, sir. Sir, it is nothing but, I mean, it's a augmented direct pathway, sir.
Direct pathway is augmented. Direct
Yes,
pathway is
sir.
potentiated. Direct pathway is enhanced. Direct pathway is
Yes.
sustained and
Yes.
sustained muscular contraction. How?
It's
How does it happen?
D1 dopamine 1, sir. Actually, dopamine 1 pathway, which is excitatory. Both the D1 and glutamate, which causes more excitatory, more GABA. That is more inhibition, little GABA is secreted, little decreased inhibition, disinhibition, which causes the motor activity.
Increased motor activity of the agonistic group of muscles.
Yes, sir.
This is from the substantia nigra. This pathway is called the Nigro striatal because it has got no other connection. The other thing is all only direct pathway only. Nigro striatal is the extra that we have added.
Yes.
Okay.
Yep.
Nigro
Yes,
striatal pathway,
yes,
also called the Nigro striatal D1P pathway. Okay. Nigro striatal D1P pathway means that dopamine 1 is the excitatory neurotransmitter which is acting here. Now let's go to the D2P pathway, which is the nigrostriatal modulation of unwanted muscular activity. Now what happens? Same substantia nigra. Now we are taking the indirect pathway now into action. Indirect pathway, what is the route? Cortex, striatum, externa, subthalamus, interna, thalamus, cortex. That is the route, isn't it? Now what we are doing now? Okay. Now, from the cortex, the excitatory influence on the caudate nucleus and the putamen is there. Now, from substantia nigra, we have got dopamine, and now this dopamine is going to sit on the dopamine 2 receptors. Dopamine 2 receptors are inhibitory, they are not excitatory. So, what they will do? Glutamine wants to stimulate, dopamine wants to inhibit. Then, what will happen? Dopamine is a powerful neurotransmitter compared to the glutamine, and the action of glutamine is rather overtaken by the dopamine, and then there is a suppression of the blue neurons from the caudate nucleus and the putamen. There is a suppression means what will happen? There is a decrease in the GABA here. Sorry, decrease in the GABA. Here GABA is minus, so GABA is the negative neurotransmitter. When these are less stimulated, here there is less of inhibition. So this neuron to the subthalamus is more stimulated. More stimulated means there is more of GABA here. More of GABA is inhibitory. So this neuron is inhibited, so much so there is an inhibition at this neuron because glutamate is reduced, and this inhibits this neuron. So much so when this is inhibited, there is no GABA here. No GABA here means these neurons VL and VA, they escape inhibition and they are hyperstimulated, and then increase in the motor activity of the unwanted muscles, increase in the motor activity of the unwanted movements is produced. Okay. What happened here? Here also increase in the motor activity of the motor activity is increase of the wanted muscles. Here there is an increase in the motor activity of the unwanted muscles when this pathway is stimulated. When it sits on the D2 receptor. Okay. Now again I am tracing substantia nigra to the putamen and the caudate nucleus sitting on the D2 receptors. D2 receptors are inhibitory. So there is a competition between the glutamate and the inhibitory one. Glutamate, so there is overtaken, the stimulation of glutamate is overtaken by the dopamine, and there is an inhibition of the neuron. Inhibition of the neuron means there is the neuron is supposed to secrete GABA. GABA is more, and then that GABA that stimulate this less inhibition means this neuron is stimulated. This neuron stimulated, more GABA is produced. More GABA is produced, more inhibition. More inhibition means this neuron is inhibited. That means there is less of glutamate. When there is less of glutamate, then this neuron is inhibited and it secretes less GABA. Less GABA means more excitation. And then unwanted motor movements will be there. So this is how the unwanted motor activities are precipitated as an abnormal movement when this pathway is activated. Okay. Now, how does D1 and D2 dopamine receptors function? D1 receptor, yesterday I have told you, D1 receptor is the receptor where the dopamine goes and sits on the D1 type of receptor. G stimulatory protein is stimulated, then cyclic AMP is increased. That increases the protein kinase activity. Protein kinase activity phosphorylates the channels there. When its channels are phosphorylated, the positive charges keep getting into the cell membrane, into the cell, and the positive charges are inside more. What will happen? The resting membrane potential is altered and threshold potential is crossed and action potentially generated. Post-synaptic excitatory potential is the end result here. This is the D1R is excitatory like GABA. D1R is an excitatory neurotransmitter. D2R, what will happen? Inhibitory glycoprotein, decrease in the cyclic AMP, decrease in the protein kinase. Channels are not phosphorylated. There are not much of positive charges moving. The positive charges here are decreased. When there are less positive charges than required, then the membrane is more already negative. So we don't have a state where the resting membrane potential can transgress the threshold potential. So that this is not possible, and then the action potential is reduced, and T2 is inhibitory in its nature. D1 stimulation is excitatory to the muscle. D2 stimulation is inhibitory to the muscle. Okay. If you understood these things, this slide I showed you yesterday, what are the various parts of the brain which are involved in particular things, I will show you later. Now, the classification of movement disorders are like this: hyperkinetic movement disorders, hypokinetic movement disorders. Hypokinetic and hypertonic: Parkinsonism, hypokinesia, bradykinesia, akinesia, postural disturbances, ataxia, speech disturbances, and a sort of pill rolling type of tremor will be there. Okay. Hyperkinetic hypotonic movement disorders, also called dyskinesias. Earlier ones are called Bradykinesia syndromes. These are called dyskinesias. What are the causes? Tremor, chorea, dystonia, then torsion dystonia, and then the tics, myoclonus, and balism. The chorea, you have Huntington's chorea also. These are the various types of common movement disorders. Hyperkine. First of all, as a clinician, you must know whether it is a hypokinetic disorder or a hyperkinetic disorder. Why the distinction is important? Hypokinetic disorder means there is less of glutamate, less of dopamine through the one receptor. So, through the agonistic muscles. Okay, and the same, this one through the indirect pathway, antagonistic muscles are relaxed. So when you don't have the glutamate and the dopamine, the antagonistic muscles become hypertonic, and the contracted muscles to contract, they become akinetic or hypokinetic. So hypokinetic, hypertonic. What you do? Then you supplement the dopamine or see that the dopamine stays there for longer time, or the dopamine is not metabolized. We'll come to a slide how we handle the dopamine at the synaptic level. Okay. Now, hyperkinetic movement disorders are the converse of it. There is excess dopamine, excess GABA, then we have to suppress the dopamine. We have to suppress the dopamine to reduce the dystonia by using agents which block the action of dopamine on receptor 1. That way, we can reduce the excitatory stimuli to the wanted group of muscles, and dystonia can be prevented. So this is the treatment. There is tetrabenzene, baclofen, haloperidol, and so many other types of drugs, not sort of levodopa. Whereas in Parkinsonism, you give dopa or dopa synergistic drugs or dopa sort of degrading drugs, or dopa degradation is stopped by MAO inhibitors or COMT inhibitors. We will see that. Whereas here we should not give the drugs like L-dopa. On the contrary, excess of L-dopa can lead to drug-induced hyperkinetic hypotonic movement disorder. So a person comes with dystonia, earlier he was diagnosed as Parkinsonism, put on L-dopa, immediately it is the excess of L-dopa. You reduce the L-dopa, dyskinesia, hyperkinesia goes away. Many a time, dyskinesias are drug-induced. So one other reason we have to write here is hyperkinetic hypotonic is something like, if you treat hyperthyroidism more vigorously, then you end up in hypothyroidism. Like that here, if you want to suppress the dopamine by giving, increase the dopamine by giving dopamine supplementation, like L-dopa, that excess dopa will result in hyperkinetic movement disorder or drug-induced. Then immediately you withdraw and give a blocker, dopa blocker, like tetrabenzene or something. So it's important pharmacologically. Now, so we have seen hyperkinetic movement disorders with these are the dystonias with this one, and then the hypokinetic movement disorders, and then the abnormal this one is of course used. So classification of Parkinsonism or the deficiency of dopamine, mostly from the substantia nigra. Sometimes the caudate nucleus and putamen are also degenerated, and the dopamine is coming to them is not able to do its action on the striatum. So commonest cause is Parkinson's disease, 80%, and then secondary like drug induced. You use dyskinetic drugs more than you suppress the dopamine, and then that can also produce drug induced this one. Toxic, vascular, hypoxic, post-encephalitic, traumatic. There are what are called the Parkinsonism plus syndrome, Parkinsonism plus also some other syndrome, progressive supranuclear palsy, Lewy body dementia, multiple system atrophy, corticobasal degeneration are the other rarer causes of Parkinsonism plus syndromes. Primary, idiopathic Parkinsonism. Secondary, it is called Parkinson. This Parkinson primary is called the Parkinson's disease, and this is called the Parkinson's syndrome because it is secondary to something else. PD is the primary, PS is Parkinsonism or Parkinson syndrome, drug-induced toxic vascular, post-hypoxic, post-encephalitic, post-traumatic, and other syndromes associated with Parkinsonism. Supranuclear palsy, Lewy body dementia, multiple system atrophy, and corticobasal degenerations. So, what will be the features like hypokinetic moment disorders are usually akinetic rigid syndromes. That may be hypokinesia or akinesia with rigidity, the opposite group of muscles. Results in resting tremor, bradykinesia, hypokinesia, rigidity, impaired postural reflexes, and later on impaired cognition, impaired speech, and emotional disturbance also. Progressive neurodegenerative disorder, resting tremor, rigidity, akinesia, bradykinesia, cognitive, speech, and emotional disturbances. Yeah, these are all the pathways we have already seen. And Parkinsonism, the pill rolling moment, rhythmic, relatively rhythmic one present at rest. This tremor is present at rest, may be temporarily suppressed by the movement. Resting, static, non-intention tremor. Intention tremor is a feature of cerebellar. This is a resting tremor, pill rolling type, as though they're rolling the homeopathic pills between the thumb and the first two fingers, index and the middle finger, as though you are asking to make small balls of Godum Pindi or some pills like that. That is the moment mostly that is there. Rigidity, because there is the opposite muscles are not relaxing. So there is rigidity there. Rigidity is of the cogwheel type, lead pipe type and cogwheel type. There are two types of rigidity: clasp knife rigidity, lead pipe rigidity, cogwheel rigidity. Clasp knife rigidity is a feature of the pyramidal disease. Whereas lead pipe rigidity and cogwheel rigidity, cogwheel means you would have seen a wheel with in the steamers, there will be jerky moments. It comes and next stops again, jerks and jerks and jerks, and that rigidity is not continuous. It works and occurs like a cogwheel jerk. Lead pipe is uniform like a plastic rigidity. As though you wanted to bend a lead pipe, it is rigid, and then it bends very smoothly finally, and there is no breaks in that. Whereas clasp knife, there is rigidity felt in the beginning, but as you approach the final part of the flexion or moment extension, then it suddenly increases the speed and closes. And the rigidity is released. That is called the clasp knife rigidity, which is a feature of the pyramidal disease. Bradykinesia, we have said, the typical phase is there is a sort of akinesia, bradykinesia, typical Parkinsonian facial animations are decreased, there is decreased blinking, and then patient is expressionless face, and then emotionally also disturbed. You can see the stooping type of posture, there is propulsion, there is retropulsion, that is, if you push the patient, he will be able to go forward, but he will not be able to stop because the antagonistic muscle do not know when to stop, keeps on going as though he is about to fall. Likewise, if you push him backward, he shuffles backward and backward without taking a halt. This is propulsion and retropulsion. Light flexion of the neck, slight, he will be leaning onto one side, particularly usually if one side is more affected. Asymmetric in reducing, swinging arm, one arm swings more, the other arm doesn't swing at all. Slowing of the gait, very slow, short stepped gait, small steps, slow, small stepped gait, and then without much of arm swinging, and asymmetric arm swinging. Shortened stride length. Stride length is ఒక కాడుకి ఇంకో కాడుకి మధ్యలో ఉన్న దూరాన్ని stride అంటాం. That is short stepping gait, which is again shortened stride. Intermittent shuffling, as though he is shuffling with chapels. Sometimes we have to shuffle. If there is a line, we are asked to shuffle. We will start walking, we will shuffle. like that they will be shuffling, and ankle dystonia may be there, inability to turn quickly to right or left side and look forward. And then there will be propulsion, and retropulsion steps become shorter and more uncertain. There is fistination. Fistination is a patient's confidence in starting a movement. Is fastidious, very slow, where he doesn't initiate, and is afraid that he may fall. Fear of falling further contributes progressively to the hesitant gait. So usually after 5 years of disease and significant impairment is rare in the early PD unless you have the eye of suspicion, you will not be able to diagnose. And if you start treatment early, you can stop the progress to a great extent and give them a better quality of life. These syndromes already I have told you. Yeah, now you can, of Parkinsonism, now you see the frontal cortex, glutamate to the striatum, and frontal cortex directly to the brainstem and the spinal cord, which are the corticobulbar and corticospinal tract. And once the striatum has come, the direct pathway is augmenting through the internal segment of the globus pallidus, goes to the thalamus. Glutamate is produced, glutamate is green, GABA is red is inhibitory, and glutamate is excited. Here, less of from this one. And if you have through the D1 receptors, the substantia nigra produces, acts on the D1 receptor, potentiates the external pathway or the direct pathway, and then that is the thalamus. Through the thalamus, the desired muscle action is increased. Whereas if you go to the same striatum through the indirect pathway without substantia nigra, indirect pathway, globus pallidus interna, the globus pallidus externa to the subthalamic nucleus to the interna to the thalamus, and that one. This is an inhibitory pathway. Okay, now this because this is more of GABA. GABA is inhibitory. Here GABA is less. This is so there is excitation is more. Here GABA is more. There is more inhibition in this path. Now again you see it goes substantia nigra instead of on the D1 receptor. If it goes onto the D2 receptor, it again goes through like the internal pathway. It potentiates the internal pathway, and then what it does, it inhibits the unwanted movement, whereas the first one increases the wanted movement, facilitates the wanted movement. This inhibits or reduces the unwanted movement. That is why the dopamine acts synergistically. Dopamine 1 synergistic with glutamine, dopamine 2 synergistic with GABA, it will act. This is how you have to understand. The causes of Parkinsonism are environmental factors, aging, genetic factors, oxidative stress, exocytotoxicity, lack of protective mechanisms, and then mitochondrial damage to the cells of the basal ganglia. There is apoptosis of the cells, particularly the substantia nigra, loss of nigral cells, loss of dopamine, loss of other cell populations, loss of other neurotransmitters can also occur. Basically, substantia nigra degeneration. Okay, now you see the hypokinesia, rigidity, rest tremor, postural instability, propulsion, retropulsion, leaning position, and then hypokinetic, hypertonic syndrome. This is unilateral beginning of the disease. Beginning, it may be one-sided more, then it becomes bilateral. Positive effect of levodopa, you give levodopa, they become better. When they're asked to sit, always the head is dropped because the opposite muscles, they're not able to sustain the contraction, the head position. The opposite muscles are hypertonic, so they pull the head by gravity forward. Absence of postural instability, autonomic symptoms may be there, cognitive disturbances, and finally, emotional disturbances also can be seen. Now, how do we interfere with the treatment of that? Before that, you require to know this cycle. So phenylalanine is an amino acid. Phenylalanine does not have a hydroxyl group on the benzene ring. As you can see, the benzene ring is double bond unsaturated. There is no hydroxyl group. Now the first hydroxylation occurs by phenylalanine hydroxylase. This is the hydroxyl group is added, and that produces an amino acid called tyrosine, which is dark in color, brown, dark brown in color. Structure of phenylalanine and tyrosine is same except for the hydroxylation. Then there's further hydroxylation of tyrosine occurs, which is dihydroxyphenylalanine. DAPA is what? Dihydroxyphenylalanine. One hydroxyl group, another hydroxyl group. Dihydroxyphenylalanine is DOPA. And this has got a COO double bond group here. Here also COO double bond is there. Here is this is all are acidic. Now that CO will be removed, decarboxylated. And once that is decarboxylated, the acid becomes an amine. And that is what is called the dopamine. Okay, phenylalanine, acidic amino acid, no hydroxylation. First hydroxylation, the ortho position and the para position, and that gives us monohydroxy phenylalanine, which is also called tyrosine, which is black in color. And from then onwards, the black color continues. That is again an acid tyrosine. It has got COO group. Then what will happen? One more hydroxyl group is added. That is by the enzyme tyrosine hydroxylase, phenylalanine hydroxylase, tyrosine hydroxylase. Then you have a double hydroxylated phenylalanine, which is called dual hydroxylated phenylalanine, dihydroxyphenylalanine, which is called DOPA, and still it is an acid. If that acid is decarboxylated, that is COO is removed by DOPA decarboxylase. DOPA decarboxylase is a very rate limiting enzyme in this particular reaction. DOPA decarboxylase is essential to form dopamine. This enzyme is the rate limiting enzyme. And either you can increase the activity of DOPA decarboxylase to reduce dopamine, or you can suppress the DOPA decarboxylase by drugs to increase the, if you suppress DOPA decarboxylase, less dopamine is produced. If you, if you suppress the DOPA decarboxylase, then DOPA decarboxylase doesn't act, so dopamine is not produced. If you enhance the DOPA decarboxylase, more dopamine is produced. Dopamine is an amine, no more an acid. This dopamine has to be catabolized, and it has got to become beta hydroxylated. So again, there the two hydroxyls are there, and then dopamine beta hydroxylase, that is one hydroxyl group, is rather added here. So from here, and that becomes norepinephrine. Okay, the beta position of this carbon atom, there is a hydroxyl group added, HCH, CH2 becomes HCHOH. That is norepinephrine. And then phenylalanine N-methyl transferase, also called catechol N-methyl transferase, COMT. This is also called the phenylalanine N-methyl transferase or catechol O-methyl transferase. This enzyme produces epinephrine. This enzyme degrades it into an unwanted thing. So you can manipulate the level of DOPA by various mechanisms. How can I do that? I can stop the DOPA from catabolism by using a MAO inhibitors. I can stop the reuptake. There is a reuptake, and if you can remove the inhibition of reuptake, or you can use the COMT for the catabolism, or you can use L-DOPA supplementation, which is converted into DOPA, tyrosine into DOPA, DOPA decarboxylase, dopamine, and you can use DOPA decarboxylase here. So we have COMT, we have DOPA decarboxylase, we have L-DOPA substitution, we have MAO inhibitors, we have reuptake stimulators and reuptake inhibitors. And this is D1 receptor, D2 receptor, We know if D1 receptor is facilitatory or excitatory or agonistic, on the agonistic muscles it sustains. D2 receptors are inhibitory and it releases the antagonistic muscles from contraction and makes the contraction a smooth one. So this is the biochemistry part of it. And so lower D levodopa drugs, dopamine agonists, and then MO inhibitors like selagelin, amantadine, which is again acts similar to the MO inhibitors, COMT inhibitors, anticholinergic drugs, they counter the action of the dopamine because dopamine ultimately is a sympathetic type of hormone. I mean, the chemical, isn't it? Dopamine. So its opposite is anticholinergic. And cholinergic is opposite. So if you reduce the cholinergic activity, then the sympathetic activity is balanced more. So there's no inhibition of sympathetic activity. So use anticholinergics also. So these are the various levels of drugs that you use. First of all, supplement the dopa by levodopa or dopamine agonists. You can use like a Merapex or Pronaran, or you can use MO inhibitors, or you can use catechol-methyltransferase inhibitors, or you can use amantadine, or you can use to potentiate the dopamine, you can use anticholinergic drugs like cyclodol. So this is the drug treatment. This also I have said. And what is the treatment for surgical treatment? Stereotactic destruction of the thalamus and pallidum, or DBS. Another methodology is called the deep brain stimulation of thalamus, internal segment of the pallidum and subthalamic nuclei. These are stimulated, or you can use embryonic cells to transplant dopamine producing cells. What is Parkinsonism? Parkinsonism is dopamine deficiency. So by destroying the thalamus and pallidum, you can reduce the inhibitory influences. So much so the dopamine is excitatory influences are facilitated. Deep brain stimulation, similar way, or transplanting the dopamine producing cells, embryonic cell transplantation. These are all the various methods of non-medical management of Parkinsonism. So we will do this dyskinesia at a different class. So we have finished the hypokinetic syndromes till now, and all the mechanisms also we have finished. We would stop here, and then we will probably do the dyskinetic syndromes in another class.